regard to populations in situations of vulnerability. Now, the research results of the joint PAHO and O'Neill Institute effort that you're going to hear about today are, we hope, of great import to the region in that they represent a key attempt to start to follow up on these Commission's recommendations by offering a first mapping of countries' stated commitments to health equity and the right to health as laid out in their national health plans. Now, we do know that the limitations of this mapping are many. They certainly do not represent the full picture of how each plan has been implemented and enforced, nor do they take into account the myriad considerations governments make in drawing up policy and the other sectorial or non-health plans that impact on health equity. They also only reflect what is included in publicly published documents, and not what could be included either. So there is no normative judgment that's being made here. We much more we know that needs to be taken in terms of action with the countries. But that said, despite these limitations, we do think that this is an important first step to at least, at the very least, start to develop the evidence base regarding what commitments countries are making towards health equity in at least the health sector. These commitments are, of course, the basis of any other action, hopefully, and we do hope that in the future we will be able to examine in more depth those other actions and also particularly their impacts on health equity. The funding for this research was provided by the Robert Wood Johnson Foundation, which, as many of you know, also has a deep commitment to achieving health equity in the region. And in that regard, we're very grateful that Alonso Plau is able to be with us today to provide a much welcome commentary on the research to close out our panel presentation. We're going to start, however, with a presentation from the O'Neill team. There'll be, as Adria also already said, I think, a question and answer session that will follow the O'Neill presentation and Dr. Plau's commentary, and Adria is going to help to moderate that, and you can put your questions or comments in the chat at any time during the presentation or wait till the end. So I'm going to go ahead, and I'm very pleased to be able to present our panelists for this afternoon. We have with us Dr. Matthew Kavanagh, who directs the Global Health Policy and Politics Initiative at the O'Neill Institute for National and Global Health Law. He's a political scientist by training with a long history of work in global health policy and politics. His research and writing focuses on the political economy of health policy in low and middle income countries and the political impact human and constitutional rights on population health. Dr. Kavanagh completed a PhD in political science from the University of Pennsylvania, a certificate in health law from Penn's Law School, has a master's in communities and policies from Harvard University and a BA from Vassar College. He's currently assistant professor of global health and visiting professor of law at Georgetown University. Eric Friedman is also with us. He's the Global Health Justice Scholar at Georgetown University Law Center's O'Neill's Institute for National and Global Health Law. He works on global health and human rights projects and scholarship with a focus on equity, empowerment and accountability. And he received a JD from Yale University School of Law. And finally, from O'Neill, we have Laura Norato, who is an associate with the Global Health Policy and Governance Initiative at the O'Neill Institute. She has training in economics and law and works on global governance and cooperation policies concerning HIV in developing countries. She holds a BA in economics and a Juris Doctor degree from Los Andes University in Colombia and an LLM with distinction in global health law from Georgetown University, where she was the recipient of the Global Health Law Scholarship. And from the Robert Wood Johnson Foundation, we are happy to count upon the presence of Alonso Plau, who is the Chief Science Officer and Vice President for Research, Evaluation and Learning at the Foundation. He's responsible for aligning all of the Foundation's work with best evidence from research and practice and incorporating program evaluations in organizational learning, and also oversees the 2 grant-making portfolios focused on innovation and emerging issues, pioneer and global ideas for US solutions. Dr. Plau has been a national leader in public health practice for over 25 years. He earned his PhD and MA at Cornell University and his MPH at Yale University School of Medicine's Department of Epidemiology and Public Health. He is currently Clinical Professor of Health Services at the University of Washington School of Public Health in Seattle. So again, welcome to you all. As you can see, we have a very distinguished group with us. And without any delay, then I would like to pass over to the UNIL team for their presentation.
Anna, thanks so much for joining us. We really appreciate it. And we're really thrilled to get to partner with PAHO on this effort. So I'm Matt Kavanaugh from Georgetown's O'Neill Institute, as was said, and I think what we've learned so far is that all of us have spent way too much time in school. The project at hand, though, has less to do with that than it does about health equity. And what we are really glad to be able to partner with PAHO on thinking through is, what does it look like for us to take seriously the issue of health equity policies in the Americas that we hope can be a first step to a broader effort to kind of both understand and support transition towards the maximally inequality improving policy environments that we could imagine. Obviously, health equity matters, and the degree of relative inequality matters as the goal for leaving no one behind, but also the goal that we know of improving health inequality, because that matters for broader issues in society. And if it does matter, then we have to plan for it, we have to measure it, and we have to have accountability for achieving it. And so this project, kind of builds off of that work, and we're going to go to the next slide. You'll hear from myself, by the way, and from Laura and from Eric. We will give Laura the benefit of speaking less this time, since she did an excellent version of the entire presentation all in Spanish. We'll just refer to her throughout as you have got questions. So first off, the question of kind of why equity and why policies, and then why plans, right? And so this broad idea, right, that we know that in the Americas we have a disproportionate share of highly unequal contexts, but we also know from a variety of empirical work that policy matters, right? We have evidence that we can use health policies, and that those health policies, broadly understood, can have an impact on reducing inequalities. To do so, though, what we know is that it's not just about health policy per se, but it's also about economic policy. It's everything from that to criminal law, to environmental policy, to a variety of different issues. And so if we think that the policy environment drives health inequalities or potentially improves them, then looking at that matters. We start with the question of health equity within national plans, mostly because we think that that's a first place to start when thinking about cross-national understandings of how policy is operating and how it might be available to impact health inequality as we go. As Anna said, we analyzed the integration of health equity into these national plans in the Americas region, but we looked at plans. We did not look at implementation. We did not look at a kind of wide variety of health policies that we think might matter. But what we did do was to take a rubric and apply it to these health plans so that we can understand a starting point. And so we want to make sure that we have scope conditions here about what we've done, but also I think what this does is it does give us an important starting point. So with that, let me give it over to Laura to talk us through the methodology.
Thank you, Matt. So our process of assessing both national health plans and subnational health plans, and also the national development strategies, began by gathering the plans and developing a rubric, a set of questions and indicators to evaluate those health plans. For the plans gathering, the PAHO Office for Equity, Gender, and Cultural Inclusion from the PAHO Office was very useful and essential. Thanks to their country's offices, we were able to gather all the current plans in the region and to have a picture and a map easily of all the tools that we need to have for our analysis. Our primary basis for choosing the categories, the domains, and all the questions that at the end were part of our rubric was the framework of action for health equity programs, which is a framework recently developed by the O'Neill Institute that was actually released in January 2019, and that we were using as it has several factors and useful tools to analyze equity and inclusion of equity in national health plans. We end up with a final rubric that has 10 categories, 38 questions. That might be seem long, but it actually was longer than that. We finally refine and end up with 38 questions. And we gathered 32 national health plans. The rubric is easily usable. It is constructed under a binary coding strategy indicating whether a country included or not a particular issue contained in our rubric. But if, of course, does not contain everything. And I'm going to refer to this issue further in limitations in the next slide. But it was widely validated. We tested against several countries of the region, located in different parts of the Americas. So we have different possible results. And we complemented the framework, the tests, with different discussions with the PAHO team and experts from the Johns Hopkins University, the Bloomberg School of Public Health. So what you see in this slide is just a snapshot, an image of what we were looking at when we were evaluating each country plans. This is just a piece of our STENS rubric. As you might see here, these are the yes and no answers that we gathered from the plans. Our goal, as Matthew just mentioned, is to represent how health policies understand and include equity in their plans. But of course, we know that actions that indicators include might not have all the possible elements from equity. And so we hope in this end, we can reflect at least the most important or key elements to evaluate equity in health plans. This study also provides an initial step on analyzing and coding health plans, but we are completely sure that the application of this rubric combined with in-depth and specific studies in particular issues might give us new insights, new knowledge, and of course, elements to adjust the rubric that we develop in this new initial foray. This brings me to the limitations that we face while doing the study. Some of them were already mentioned by Anna and Matthew. But first, there is an inherent limitation in the capacity of the rubric in analyzing and capturing the political contexts and discussions around the developing of this health plans in the region. With a rubric that contains questions that can only be answered with yes or no type of answers, it was impossible to capture all those nuances and the political context. The rubric isn't able also to identify the variation of the type of policies that we read. So when we were doing the analysis, we end up having more rhetoric type of plans with general guidance, objective principles, and another more technical, more granular and specific plans that explained strategies and programs and have objectives with dates. So the rubric is standardizing across a particular set of questions, but isn't capturing all these differences among the plans of the region. There's also a key element to have into account is that we draw a line where we thought something was a yes or a no. But that line might be not drawn by another expert. So what we encourage in the future is to write a coding book that actually represent the consensus among what is a yes or what is a no. What is when a country health plan has or includes an element that we incorporate in the rubric. Finally, as you see in the slide, we did not include Canada or the US and Cuba because these countries didn't have a plan that was comparable to the rest of the plans that we have from the region. We have a close relative, an example from Canada, which was the Public Health Act, but it was mainly focused on health insurance, which wouldn't give us the whole picture of Canadian public health response or public health policies. So we excluded that Canada isn't part of those 32 country health plans that we end up having for the analysis. what you see here is a picture of the final rubric that includes these 10 domains that you just mentioned, but briefly I can talk about them. We include mission and vision, if they included or not the concept of equity. Very important topic, which is social and environment determinants of health. If there were multi-sectoral actions towards equity, participatory process, and equity toward universal health. A very interesting topic also, which is inclusion of populations living in situations of vulnerability, disaggregated data and targets, which are very important too. And finally, monitoring, accountability and responsibility, and capacity to respond to health equity. Again, and as I mentioned earlier, this is, and Anna also mentioned it, this is an analysis that include a revision of the text of the health policies. It's not an assessment over the implementation or the effectiveness of these policies. So what you see here is just a summary of the final scores that each of the countries received for each of the domains that we studied. Matt and Eric are going to explain further in each of them. So I give the word back to you, Matt.
Great. I'm going to turn it over to Eric in just a second. The one thing I would just say, going back, can you go back one slide, Lara, for just a second? The one thing to just notice here is that as we go through each section, what you're going to see is actually quite interesting, right? So this shows you that we saw variation in which issues are most included in the health policies as we look across, right? So the plans that we reviewed largely see that some issues are very well covered and some issues are not very well covered. We also see real variation in countries, so that some have very robust attention to health equity and some give very little attention. But it's worth noting that none of the countries on our rubric gave attention to all of the issues that we had scored them against. And so I think this, to me, provides a really interesting roadmap for a conversation that PAHO is really driving around what does it look like to plan for health equity? How can we do it better? How do we think about different countries' strengths and weaknesses? And how do we think about tailoring health equity approaches to the context that exists, both political and health strategies? Over to you, Eric.
Thank you very much, Matt and Lara. And now, as Lara said, we're going to get into the specific findings for each of the domains. Starting just with the vision and mission, this is very positive. Almost all the plans, 30 of the 32, did include health equity as a mission. Indeed, I think the two that didn't really have a mission vision, and so pretty much it's universal. That was sort of the key finding there. Moving on to social determinants of health, we have a mixed picture. On the one hand, countries did recognize this was important. Indeed, almost all but just a few, did include some measures to improve underlying determinants of health, whether access to nutritious food, safe water, improved sanitation, and so forth. That was very good. But on the other hand, next slide, please. One thing that we looked at as well is looking particularly as we did health plans and thinking they're focused on the health sector, even though health goes well beyond, obviously, the health sector alone, was the question of, do the plans have financing models to incentivize the health system, health sector to address social determinants of health? For example, per capita payments, so the idea is to keep people healthy, and if the cheapest thing to keep people from not having asthma is to address their living conditions rather than keep treating them every time they come to hospital, that would be positive financial incentive for actually addressing the social determinants of health and not only the immediate health issue that presents. And we did not find any country that included those types of incentives in their plans. We looked at a few other issues in terms of social determinants of health. One was climate change, which is obviously a huge, huge issue. That was decent. More than half of the countries, 18 of them, did address climate change in some way. The private sector, on the other hand, sort of multi-sectoral, social determinants, even though it is such an important and growing role in many countries, and often they exacerbated in health inequities, they were actually only about a third of the plans addressed the private sector at all. So that is certainly one area that could need greater focus, or would need greater focus going forward. Next, please. Thank you. The next issue is participation. Again, we have a mixed picture on multiple fronts. We basically looked at two issues with respect to participation. One was in developing the plans themselves, and the other was in plan implementation. The first question was in developing the health plans that we analyzed, was there some process that they referred to for involving larger public civil society in developing the plans, or was it more just of a top-down government developed plan? And that was pretty good. Most countries, 20 anyhow, did describe a process that involved the public civil society. On the other hand, when we talk about health equities, we're particularly concerned, are they reaching out to are they involving the people who most suffer from these inequities, who are living in various situations of vulnerability and marginalization. And like very, very few plans, only 3 made specific reference to reaching out to those populations. Similarly, though not quite as dire, so to speak, as mentioned, as you know, social terms of health, if not the focus of these plans, are critical, an area that health sector needs to do more in, and absolutely critical to health equity. So one would hope that part of the people who are in organizations, entities involved in developing these plans would be from other sectors outside of health. A number did, but most did not. Only 14 countries did reference including non-health sector participation in developing the plans. Next, please. Again, as I mentioned, the second dimension we looked at was, once the plan is developed, looking if it's a 5-year plan over those 5 years, does the country have a strategy or processes to make sure the public remains involved as they develop policies to implement the plan, develop programs to implement the plan, and in general develop health policies and programs. Most did, as we saw, that as much as they involved them in developing the plan, they recognize this is important. So that's very good, the very strong recognition in the region that the public does need to be involved really at all aspects, developing plans, policies, programs, almost 28 of the 32 countries. But again, we see, whereas in last case, it was limited outreach to marginalized populations, or populations in situations of vulnerability. Here we asked, it's great that you're funding, that you recognize the importance of these mechanisms. Is the plan referring to any particular efforts to ensure they're funded and work well, such as training or outreach to populations in situations of vulnerability? Here we saw only very few, only 5 countries did refer to structured or funded efforts to make sure that the public is indeed able to effectively participate in health policy and program development. Next, please. Thank you. We next looked at equity towards universal health, looking really across health system dimensions, and we'll get to a few of those in a moment. One basic question we asked is simply, do they provide include a goal of providing universal health coverage? Most did, 23, so about 2/3, a little bit more. And then getting into, like I said, the different areas of health system, especially health workforce, health financing, accessibility issues, for example. That was sort of our focus in this area. In terms of health workforce, a number of countries did include actions to increase the number of health workers in communities, underserved communities in situations of vulnerability. The most did not, 10 did, so a bit of a rather small minority. Looking at funding issues, few more did, but still a minority, again, really getting to earlier point about the great diversity within how countries address these different issues, with 13 addressing equitable distribution of funding and 14 focused on increasing services for people who are in situations of poverty or facing other vulnerabilities. Next, please. Thank you. Continuing along the same topic, again, just some of the other issues. Maybe just one, if you're wondering in the middle there, since I mentioned the health workforce issue. One thing we asked, not only are health workers serving in lower income, or are countries seeking to increase the health workforce size in countries with, in areas with vulnerable populations, but are they actually recruiting people from those communities to serve in the health workforce from underrepresented communities? Maybe some are, but none mentioned that, even though that's really a key strategy. So that's something to keep in mind going forward. In terms of just going through quickly a few of these other areas where, again, you see quite the diversity. In terms of actions to address, sorry, just a second. Just 1 second, sorry. In terms of addressing discrimination is the first line that you see in that. I'll get to in just a moment in more detail. Most did not have, most, as you'll see in a moment, did address discrimination in some way against some groups. In terms of having an overall comprehensive strategy to addressing discrimination in the health sector, only about a third of countries did. In terms of physical accessibility in underserved areas, in terms of general accessibility health services in underserved areas, we looked and mentioned the one dimension of health workforce where some did, most did not. Most included something, though. About 19 countries included something to increase accessibility in underserved geographic areas. In terms of another form of accessibility for people with disabilities, a number did, but only about a third, 11 countries included actions to ensure, or at least to improve, access of health facilities for people living with disabilities. Literacy and the information, of course, is really a central part of the health system. Again, is 1/3. 1/3 of countries or so, 11, had actions focused on increasing health literacy of situations of, population situations of vulnerability, and even fewer actually address barriers to health services, language barriers, only 2, even though, of course, people in the region speak often indigenous, other languages. That was not a focus of many plans at all. And finally, just in terms of access to medicine, improving access for people in situations of vulnerability, half did, half did not. Next, please. Thank you. And then again, as I mentioned, I get back to discrimination. Here we see a very, very wide range. As I mentioned before, about a third of the plans had overall strategies to address discrimination in the health sector. In terms of which populations countries addressed it, huge variation. So, for example, countries or people living in situations of poverty, people living with disabilities, the majority of countries did. On the other hand, some other groups, migrants, members of the LGBTI community, Roma people, indigenous people, Afro-descendants, in varying degrees, these were all only minorities of countries addressed them, and some, like migrants, very, very few, even though it's a huge topic issue in the area. Maybe one thing also just to highlight here is the fact that Roma people, Roma populations, Afro-descendants, and indigenous populations are a minority in terms of how many countries address these, even though the POW Commission on Equity and Health Inequalities in the Americas actually highlights these 3 groups, especially as ones that need attention. And these plans were all developed before the report came out. So I think it's sort of just one thing to keep an eye on and to trying to encourage action on, is to ensure that going forward, countries do include not only those populations, but certainly those populations. One last point on this slide, then I think I'm turning over to Matt, is we didn't actually grade, we sort of noted in our rubric yes or no for these. We didn't grade them in terms of any sort of more scoring, recognizing that in some countries, this is less, they might not have large or even any Roma populations, and so it might make sense they don't address them. Though there certainly are, populations like people with disabilities that all countries have. So one would hope that all countries would address. Next slide, and I think we're over to Matt.
Great, thank you, Eric. So I'm just going to go through the last few slides and make sure that we leave ourselves plenty of time for discussion. But the couple other areas where we looked. So one was data and monitoring. And I mean, the good news is that, as you can see here, more than half of plans, so 19 out of 32 countries, did include baseline data on health equities in their plans for the health sector. And so I think that's very good news, right? It recognizes that many countries are recognizing that as a problem, and they're recognizing it from the start. Less good news, although only slightly, right, is that less than half, 13 of the 32 we reviewed, set time-bound targets to reduce those inequalities, whether that's health access or health outcomes. And so this to us is actually a very important point, because obviously what we plan for, what we measure, and what we set targets for gives a large emphasis on what we're thinking about and what we're valuing at a particular moment. And in some contexts, those targets can really drive impact. We also know that in some contexts, targets are not the most important thing. So we'll only go so far as to say that, but I think the key point here that we're not across the board setting time-bound targets for reductions in health inequalities is pretty important. It's also important, and that many of the plans did actually incorporate a regular monitoring and evaluation of the objectives and the targets into their plan, which was good, but only 10 of the 32 included a regular role for the public in doing that monitoring and assessing. And so that was an interesting finding that we had. Next slide. Overall, very few countries' health plans had accountability mechanisms tied to the right to health. And so this was a particular note for us, because we thought, there's a number of things, and you can read the report more thoroughly when it's out. But we thought about kind of what are the accountability opportunities, because we know how important that is for realizing the right to health, realizing reductions in inequalities, and realizing access for the most vulnerable. And so only 10 out of 32 countries that we looked at only 2 of the countries' health plans, included a very clear discussion of a mechanism for reporting right to health violations. Only 3 included investigation and reducing fraud and corruption. So it's worth noting that those pieces are not in health plans. Doesn't mean they're not happening, but they're not in the health plans. Next slide, please. We also looked at, briefly, at national development strategies. And so we thought the bulk of our work was really focused on this question around health plans, but we thought really key to all of this work is we know the social determinants of health cannot be controlled just within the health sector, and we know the critical nature of improving health through putting health in all policies. And so we looked at national development strategies as one indicator of the degree to which that is happening. We found, to start, the idea per se, health in all policies, was not a concept that made it into most development programs. Most importantly, though, about half of countries did include health indicators in their plans, and so that actually was somewhat good news to us. It showed some models for saying when we're doing a national development plan, we can include health-specific indicators and time-bound targets, right, for health outcomes that might be important. Of those, only 8 out of the 15 actually included health equity. And so we think this is an opportunity, right? That if some countries are actually putting those health equity concerns into their national development strategies, that might be a model for further work by others. Finally, we moved on to the kind of question around the patterns and what that looked like. And what we found is that there was not a whole lot of clarity and not a whole lot of uniformity when it came to the ways that countries were doing this in their national development plans, which might create an opportunity for PAHO to be speaking with the economic commissions and others about ways to do that in a centralized way. And we thought that was very interesting. Final slide. So our next slide is just some recommendations, and these, we'll share them around and would be a great starting point for discussion. We think there are clear areas where plans, as new ones are crafted, could address new areas. There's a lot more opportunity there to address social determinants. There's opportunities to really dive in and address specific populations. We did see a gap in some of the strategies to achieve health equity, even where countries were including a clear goal. There weren't always clear strategies to achieve them, and that could be a real opportunity moving forward, especially in the context of moving towards universal health. And this key point of measuring, targeting, and creating accountability mechanisms, we think is probably one of the most important findings of the work. That is a key piece that we just know drives plans and is the reason to plan in the first place. And so we think that there's opportunities there to advance them. We also think going forward that there's opportunities to advance how we're evaluating the impact of policies, to extend this analysis to others, and then to link that up to conversations around which countries are or are not seeing greater reductions in health inequalities. The countries that are seeing greater reductions, what kinds of policies are they enacting? To what degree does this align? And that's future work to be done. And then we also finally would just say that we do see a real opportunity for coordinated multi-sectoral planning and strategy to improve health equity. One idea is this idea of the Health Equity Program of Action. It's a framework for systemic and inclusive approaches to health equity, and we would urge folks to take a look at that. But the kind of core question of figuring out how we can learn from what's working, use country comparisons and cross-country comparisons to really rigorously evaluate what is the policy environment that best addresses health inequalities is one that we think needs quite a bit of attention in years to come. And we hope that this has contributed some toward that when we think about what is in the current plans in the Americas. So with that, let me turn it back over to Anna. Thanks so much.
Thank you very much indeed, Matt, Laura, Eric. That was really a great overview in a relatively short period of time for such a kind of rigorous analysis to present. And I think as was stated at the beginning, was stated various times through the presentation, this is of course a starting point. In a sense, this is looking at equity as mainstream. So by its very essence, by having to touch upon multiple different areas which can be considered to be part of the health equity framework, and both from the work that you guys have done previously, the commission, the frameworks that PAHO operates, you can't interrogate down in those so much. And we do know that there's much more work that needs to be done in terms of that interrogation, in terms of what worked, as you were just saying. And I think it doesn't include the sectoral plans that I know, particularly was commented in the last section, are very important for social determinants. They're very important also for some of the issues around gender and ethnicity, some of the specific strategies that might address some of those populations. So there's clearly a lot more work to be done. But I think this was a really great start point in terms of at least what's out there publicly in terms of the commitments, because that really gives us the base. You can't expect countries to do much more if it's not there as a stated commitment. So I think this is a great starting point to be able to go further and interrogate further. And with that, I would like to turn over to Dr. Plow, who is going to give us a brief commentary from the point of view of the Robert Wood Johnson Foundation, both in terms of the studies and also more generally perspectives on health equity. Alonso.
Great, thank you, Anna. That really excellent presentation and really tees up of the issues and the challenge of measuring equity and specifically health equity. So in my brief remarks, I'm going to reflect on how challenging it is to measure equity. More complicated than measuring disease presence or absence, right? It's a complicated concept. in particular equity as it relates to health equity. And at the foundation, we define health equity as a fair and just opportunity to achieve the best possible health and well-being. That is our operational definition of what we mean by a culture of health. All institutions, all mindsets converge around that. So obviously, getting to equity is a journey, and one that is collaborative beyond the health sector. For us, I think it's intrinsic in what you were saying in your analysis, essentially what wasn't there that should be there in the report. This involves eliminating any factor that restrict health equity: poverty, racism, gender inequity, other conditions that marginalize segments of the population. That'll vary from country to country. We find it difficult, and I'm saying since I work mostly in the United States, to measure our index health equity in just one country. You took on trying to look at this across most all of Latin America. So you get huge kudos simply for taking on the scope of this and raising up such an important set of issues. It's an important study and a really solid starting point for future work. And the methodology you used was rigorous, but it's limited in two important ways. But as you also said in your presentation, as researchers, we'd say it's limited by your source material, right? And you did with it what you could. But I think many of my comments in your conclusion really suggest other ways to provide data and information that can go forward. So, again, the two, and again, you mentioned a lot of this in the presentation and in the report. You had to do binary coding of quite complex elements of equity as represented in published national health plans. So that's a limiting factor there. And second, even like in most of the Americas, certainly the United States, health plans disproportionately focus on traditional healthcare services, insurance, those things that may make up the biggest budgets of countries, but aren't necessarily related directly to powerfully changing equity outcomes, and not those broader social and economic determinants of health equity. And again, the authors, you all recognize that in your recommendation. And the challenge to top-down healthcare planning is because they don't often engage marginalized populations in plan development. You pointed that out. And the issues are much more complex than binary coding can tell us. And as you talked about, and it's so important going forward, we need to understand the capacity to respond to health inequities, get a little deeper onto how policy intent becomes practice and action to achieve health equity. Those are the next level that you suggest we pursue. So plans and the foundation, we do a lot of work on this, both domestically and internationally. Plans become action when they are linked to deep community engagement, particularly including marginalized populations. We're doing a lot of funding now in community power building because we think that is a major avenue to address some of the issues and inequity we see. And as I think you also suggested, a case study approach on a country by country basis would really help us understand this, particularly, again, as you hinted at in your discussion and in your recommendations, how you got to get the non-health sector involved. Because the whole premise of social determinants is that largely the non-health sector are the drivers of these outcomes, and they are only at the margin controlled by the healthcare sector. And I think that's and the kind of planning and analysis on a country-specific basis should look at that. I think, we've been working on this like you do a lot. We're saddled by traditional health care statistics, which are disease statistics and not equity statistics. And we struggle for what is a metric of health equity, and we don't measure the structural manifestations of racism and discrimination that set this causal context for inequity. And so in health plans, We don't have the kind of data that brings in segregated impact of segregated neighborhoods, disinvestments in schools in impoverished neighborhoods or rural areas that limit educational opportunity. I mean, restricted access to capital, living wage jobs in marginalized communities, persistent poverty and despair. Those drive these outcomes that we want to change. And the challenge of health planning is to connect to those sectors that actually control and determine those outcomes. I think we find in our work, when we get deeply in communities, tremendous reserves in communities of individual resilience in the face of all these pressures. Tapping into that better for ideas and collaborations really help us understand how we can improve equity over the life course. And I'm probably thinking about the US currently now when this next section of my comments, we're seeing right now that endemic racism, which is a critical factor driving our COVID-19, our police violence, and our general health disparities, we have to confront that directly to get to equity. Because if you don't confront it directly, you won't get there. And endemic racism and endemic discrimination creates a dehumanizing narrative that creates disregard at one end or actual hateful acts of violence at the other, which we've seen with the George Floyd killings. So all of us involved with equity work, and it'll vary from country to country, need to deal with that context. And as a New York Times reporter said, and I've been quoting it, policies either address these things explicitly, they're anti-racist, or they are they perpetuated because they don't. And I think it's really important that that's the challenge to policy. And again, I think you raised all that in your analysis of what important things were missing, given the kind of restricted nature of the data that you saw, particularly in that last couple of slides. The disconnect between the broader development planning, economic development planning, social development planning, and health planning. The challenge for all of us in all of the Americas and globally is to make that connection. So again, in closing, your study and recommendations are really important contribution. I don't think anyone knows how to analyze this. There is no state of the art, though I think there are just a number of us across the Americas and globally. And I'm working on this. And the good news is we're moving to an equity frame from simply just a disparities frame, which allows us to think about positive health and well-being in a way that we couldn't before. So kudos to what you did. I really appreciated your presentation. And those of you who weren't on this morning, I really appreciate doing these comments in English versus my first attempt to do them in Spanish earlier today.
Thank you, Alonso, but you misrepresent yourself because you did a great job also this morning in Spanish, but I do recognize that you were able to expand a little bit more in the English, so that's fantastic. And thank you very much indeed. I don't want to take too much space because we only have 10 minutes and I want to give space to other people, but I think you really did illustrate that, this is a fantastic starting point. It's never going to be perfect. It's a lot more to do, and we really hope we can do that because it's definitely necessary that we expand the evidence base, not just for the sake of the evidence-based, and but as was also commented this morning, Oscar, who's connected, made the comment that we want action. So, but we want that action in a way that's going to be effective. So I think the more we can know about what actually works, is going to put us in a much better place to be able to really advance towards health equity. So I'm going to stop there, but just saying thank you to both Neil and to Alonso, and I'm going to pass over to Advia just for the last sort of 10 minutes, I think, to see if there's any comments or any questions that people would like to ask, especially of the team at O'Neill here.
Yeah, I think let's not even waste that time. Anybody who has a question, you can raise your hand in the chat, in the participants pane, or you can send a question by chat. Oop, going once.
Adria, I think there's two people with their hands raised.
Okay, my screen might be frozen. Can you see their names? Because I can't. Oh, I see it now.
Yes.
Okay. My screen refreshed. Okay. Any of you can start just because the time is short. If you have a question, you can turn your microphone off mute and say a question. Whoever starts first.
Well, I don't know who any of you is, but hi, this is Gerry Eikemans. I'm the head of the Social Determinants of Health and the Health Promotion unit in PAHO. I'm very happy that this study happened. And I think it's, as you're saying, you know, it will always be to always have imperfections, etc. But I do have a couple of questions, something that really, you know, call my attention. When I see the proxies or the rubrics or whatever you call them that are being used to talk about social determinants of health, it's really about living conditions, you know, it's not about power, it's not about resources. It doesn't look really at the structural determinants of health. Then, you know, climate change, I mean, I wouldn't call that a social determinants of health. The social determinants, of course, influence how climate change affects people. The money invested in social determinants of health obviously doesn't happen in the health sector. So these are, I think that's a real problem, you know, to say that social determinants of health is not reflected in the health plans if we use the wrong proxies. I think that's just a problem. And the other thing has to do with multi-sectorial and then taking the private sector as the entry point or as the proxy. That's also, I mean, we use the intersectorial language, not so much multi-sectorial, which more the NCD language, no? That is also something I think we really need to look at. I really liked that you looked at the national development plans, because that's where we see, and everybody's worked in the countries knows, there is not one single country in this region who does not have health in one or another way in the national development plans, linked to the national development plan. So I think we also have to try to start to see how we can pick that up now, how we can pick up the language that's being used, which is definitely not health in all policies. That is an invention of our own organization, and it has not really been picked up very much as a concept, but it has been picked up in terms of intersectorial work. So I think these are a couple of things, and so I'd like to also, there's a lot of intersectorial mechanisms in the countries around early childhood development, around violence, around education and girls, around road safety, etc., that are not necessarily come out in the health sector analysis. So I think these are some things I'd like to hear, and particularly about how can we improve on that? You know, what can we do with this? First of all, how can we use it, and how can we improve on that? And I really like the last point also that's made by Alonso about community participation, using the community assets. And that's something that I think we can also find better ways to pick that up, because that is, Latin America is actually famous for that. And they have done a great deal, again, maybe not necessarily in the language that we're looking for. So thank you so much. A great first step. Really, we would be very happy from the technical point of view also to get involved in this work more. Over. Thank you.
Thank you very much, Gerry. Oh, sorry, I thought Adria disconnected, so I'm going to. I was thinking, but she's back, so I'll leave it to you.
Anthony, you're next with your hand raised.
Yeah, thank you very much. Really enjoyed the presentation, and congratulations. I'm Anthony. My area of work is people with disabilities. So it was great to see the 2 questions that were included in that, and I've already been in coordination with Adria about how I can use that a little bit more. My question is twofold. Firstly, what would a next step look like for you as someone like me who focuses on one sort of specific population group or area? How clearly that skims the surface to look at sort of where things are. What would you, if resources and context were not a challenge, what would you love to see doing on a more sort of deeper level in those things? And the second piece is the sort of intersectionality between different areas. So we talk about people with disabilities, but then we know that people with disabilities or a queer, disabled, Black person faces double, triple discriminations. And where is the opportunities to look either at policy or implementation of those sort of overlapping areas as well. I'd be super interested to look at that.
Thank you, Anthony. Does anyone want to respond? Give any ideas?
I can give a quick start, and maybe Eric and Laura, please come in. I mean, this is really helpful. So thank you, Alonso, for that really helpful interaction, and thanks also to other two colleagues. Just super quickly as we're thinking about it. One, I think the core as we looked at these pieces was to say what's in a plan and what's a plan trying to do, right? And so I do think that we probably could go deeper and more complex when it comes to structural determinants of health. That's actually very helpful, and thanks for bringing that up. I'll just say that we did not find those issues either, right? It's not, unfortunately, it's not that we were we saw issues around housing, but we were missing the big issues of structural power, right? So I totally agree, and so would love to follow up on kind of ways to measure that and ways to think about that, as Alonso was saying, because I think that is really critical. And we saw even less of the big structural meaty questions within the health sector, right? Which in part was we were looking at health sector plans. And so one question is, what's the ambition of a health sector plan, and how intersectoral or multi-sectoral is it, and could it be, and should it be? Other suggestions about where to look for those is also really helpful, right? And so thanks for that. And I think also, especially on the community assets piece, right? I think this was critical, and we tried to approach it in a few different ways. We looked at community engagement, we looked at community health workers, we looked at a couple pieces, and I do really think this is one that's not well reflected in health plans, and especially as a strategy for health equity could be just incredibly useful. So as we think about kind of what might PAHO do and what might we do, I think there's a huge opportunity for PAHO to really look at that and think about that. And then for us, finally, just to step back for a second, there's this idea of, are there countries that would want to take on some deeper measurement and some deeper looking at how would you plan for health equity? What would that look like? What would good metrics be? And I don't know that we can do that on a single axis, right? And so there is that intersectionality that was mentioned, whether it's people with disabilities, et cetera, where I think it's very hard to create an effective plan and strategy that does only pull one piece out. So how could we pull that one piece out and use that as a leading strategy to address broader health equity issues, where what we're doing is we're putting big, hairy goals out on the table, where we're going to measure them, we're going to detect them, we're going to say what the goal is, and we're going to say whether or not we met that goal at the end, and then we're going to put clear strategies along with them. So I think there's a lot of room for that, but it was really interesting to us to see, one takeaway from us is that no country has everything we want. But another clear takeaway from us is that there's a lot of pieces out there in these plans. And so it's not, almost everywhere we could find a country that was doing something very interesting, robust, exciting on this front. And so to me, that actually gives great hope for bringing together strategies and using planning as a strategy to address health equity going forward. I'll stop there.
If there's time to...
Go ahead, Eric.
Yes, thanks. Just a few very quick points, and we're sort of low. One is on the question of addressing the structural issues. Again, I totally agree that's so essential to this. It's hard to sort of find in health plans. We did look to see whether there's sort of one bit of a proxy. Are countries mentioning in plans, recruiting people from communities in situations of vulnerability into management positions within the health workforce? That was part of one question, and none did. So we tried there, but I think it's a huge issue and something we struggled with, recognizing on the one hand, this is sort of so central. On the other hand, how can we find that, and how much can we expect that just in the health plan? And then the second quick point with respect to people just living with disabilities and intersectionality, or 2 points. One is, given that the plans themselves didn't go into great detail, I mean, they often include particular groups, but didn't go into great detail often. I think in terms of more what are countries doing, it does take a deeper dive into the policies of specific countries, looking beyond plans. Then intersectionality, I think that just gets the importance so much of the community engagement and assets, and having as part of these processes, the plans, developing them, going forward, not just plans, but the policies, the programs, having participation and active outreach to ensure that you are getting diverse communities, including capturing that intersectionality within the plans. It's hard to, have a plan for every possible intersectionality, or every combination of characteristics, but through participation, I think that's where an engagement, that's where a lot of that could happen. But then you need a very robust strategy on ensuring that really meaningful engagement.
Thank you, Eric. We are at the end of our event. We're actually a few minutes over. So I appreciate all who may have additional questions. I think this is a great opportunity for us to continue this conversation, both within PAHO and also with our partners at O'Neill and Robert Wood Johnson Foundation. But I'm going to pass to Anna to close our session out for today.
Yes, thank you. And I'm just happy that my internet lasted the whole of this session. But I know that we're over time. I know that there's a lot more to discuss, and I think actually one of the things this illustrates is that maybe we should have allowed more time for this discussion. But I think this was, like we've said many times, this was a great starting point. I think what it illustrates, and it's maybe slightly overwhelming, how much more needs to be done. And I think that we're very happy to have been able to partner with you, the team at O'Neill. We're very happy to be partnering also with Robert Wood Johnson Foundation. I think that gives a really powerful base to move forward and to think about all these different areas in more depth than this was able to do. Like I said, this is a top level approach to what's already out there. I think we've taken some really good points from the discussion, and I hear Jerry as well in terms of maybe those things about health and health policy may not be using precisely the terminology, and maybe we need to look at what's actually happening, and maybe it's not even in the health plans, it's maybe in the sectoral plans elsewhere. So again, much more that needs to be done, but I think this is a great starting point for us. I do want to mention that there will be there'll be a report published on this, but there will be an article that's published in the special edition that's coming up on equity of the Pan American Journal of Public Health, on the special edition on equity that will be published hopefully around September time, and there will be an article in this that's going to look at some of these results as just been outlined today. But I want to thank you all very much, just both the team at O'Neill and Alonso, but as well all the people who have connected today. And definitely this is a conversation that will continue, and I hope that it will continue, because I think there's a lot more to be done, as I said. But thank you very much indeed, and have a great day, everybody.
Many thanks.
Thank you, Anna.
Thank you.
Bye.
Thank you, Anna and Ija.
Thank you. Bye-bye.
Thank you. Congratulations. Great job.
Thank you.
Thank you. Bye.
Thank you very much.